I'm Dr. Tom Habermann, Mayo Clinic, Rochester, United States. We've just had a remarkable session on novel diagnostics and biomarkers and a very vibrant discussion afterwards. And my first question of Dr. Bjoern Chapuy is, where are we going to go? You presented such an elegant biology on 5 cluster designations in a very now complicated diffuse large B-cell lymphoma that with a median number of mutations of 17 in patients. Where are we going to take this next?
Well, thanks, Tom, for this question. I think that's an excellent question. I think, first of all, I think we are very happy that we have now a comprehensive genomic landscape of primary diffuse large B-cell lymphoma. And with these 5 unbiasedly identified clusters, which are comprised of mutations, copy number alterations, and structural variants, I think we have now a framework which we can use to, A, predict outcome independent of the IPI, our clinical risk model, B, have a roadmap to design new model systems and, importantly, rational combination therapies. And I think, this is where we have to go. So now you will ask me how we might do this practically, right? Because we did this study with exome sequencing and we need to drill down these. Particularly, I was having like a competing or an alternative classification, which is also very elegantly and partially is overlapping despite the fact that it's coming from a complete different angle. So to this end, I think, it's now our requirement to provide the community with a molecular classifier which allows on a drilled down set of genetic alterations to predict all of your different classes, which is then able also to predict single patients which come in maybe on Friday afternoon in your clinics. And I think we're working very closely on that to provide the community with a particular algorithm.
I had the privilege of chairing one of the 3 RCHOP trials, and RCHOP is still 25 years later a standard of care in DLBCL. My hope is that we could move this forward based on these kinds of observations.
Yes, I totally agree. And I think, that one of the challenges we're facing, and I think I've pointed that out, is that this high amount of genetic complexity with a median of 17 genetic drivers in DLBCL is probably the reason why just adding 1 or 2 different drugs to a backbone of chemotherapy is not helping. On the other side, it's probably also the reason why some chemotherapy, which is kind of not targeted, if you want, is so effective because you have so many different clones which were eradicated with this particular treatment. So moving forward, I think that we need to understand and model these particular clusters in a rational fashion, identify which are rational combination partners, and then move forward. And we can do this prospectively using model systems and retrospectively use all the failed trials, failed in terms of the patients didn't benefit from the additional component, to retrospectively apply our cluster model and then identify those subgroups which might benefit from a targeted therapy.
I agree, and the number of trials done the last 25 years, all negative trials, is really a disappointment. But people have been trying internationally. So we really appreciate your work and your effort, and I think it's another example of multiple institutions and countries involved in providing specimens, and that's the future. So our next talk was on in T-cell lymphoma, and Dr. Nicolas Ortonne did a talk on biomarkers for diagnosis and treatment of cutaneous T-cell lymphoma. And this disease has been an extremely complicated disease. We didn't think it was, we always thought it was heterogeneous, I think, as opposed to large B-cell lymphoma. But what about where we are now with the molecular alterations, and where might we be going in this complicated group of disorders?
Well, thank you for this question. I think it's a very important issue. The mutational landscape of CTCL has been extensively studied in the past 3 or 4 years. Before we didn't know anything. And especially in the Sézary syndrome and mycosis fungoides groups, which are amongst the most frequent CTCL. There is still a lot to do because there are many CTCL entities in the WHO classification, and we know very few things on those molecular alterations that may be targets for therapies and also allow the development of new biomarkers for diagnosis. So what we have learned is that there are many different alterations with few recurrent alterations in Sézary and mycosis fungoides, targeting similar pathways as other PTCL, such as iwNHL, angioimmunoblastic T-cell lymphoma. They involve the TCR signaling, and the best examples are CARD11 and PLC gamma-1 that may be present in up to 20% of cases. The cytokine receptors, and there are often activating mutations of the TNFR2 gene. Those mutations can affect some epigenetic regulators, especially MLL2 and MLL3 in MF, and ARID1A and DNMT3A for Sézary. And also they are very frequent in alteration and deletion of the p53 genes. So we have now a better overview of the mutational landscape of those lymphoma, but it is noteworthy that many studies were published in the past 3 years by different groups, and they found different abnormalities. So I think those lymphomas are very heterogeneous at the molecular level, and we should go on to study these lymphoma at the molecular level to try to determine if there are different subtypes at the molecular level, just as you did in diffuse large B-cell lymphoma. And I guess they are, and that those studies will allow to obtain new predictive markers for therapy, just as in B-cell lymphomas.
So last question for each of you. 10 to 20 years from now, we're going to be using the word Sézary syndrome, mycosis fungoides. Are we going to be using the word diffuse large B-cell lymphoma, or will we define these molecularly?
Well, I think there's no question that we will move forward from here in a more molecular, fine-grained detail, because, you know, I mean, we are now using a chemotherapy backbone which has been defined in the last century and has been holding up since, right? It has been added with rituximab 20 years ago, and it's not like nobody tries to improve on that, but it's very clear from our data that you need to think just not one step ahead, but maybe two, and how you can combine different things. And I think that's what we'll learn in the future, that we will always refine our classifications, but that we now have a couple of roadmaps in our hand how we can rationally combine targeted therapy, and I hope that eventually that helps the patient.
Thank you very much.